Hello everyone, myself Dr. Namrata Vitlani. In this video, we are going to discuss an important case of cardioembolic stroke. So, patient was a young male, 30 years old. He presented to us with a history of inability to speak since half hour. So, patient was aphasic on admission, and so clinically we suspected some form of CV stroke which was presenting to us on it, and we evaluated the further neurological examination. The all four limb movements were present. Patient was able to move all four limbs. He was fully conscious and oriented. So higher mental function were normal, and patient was able to move all four limbs, able to walk independently. The only complaint was inability to speak and the facial deviation. So patient had seventh nerve palsy and aphasia. So we explained the patient's relative regarding the need for the neuroimaging MRI brain. So on written evaluation, we further investigated to look for the cause of stroke. So on ECG, we done the ECG of the patient, which was as mentioned, which was suggestive of ST elevation in the V3 to V6. So changes of old MI were evident on the ECG. So next we did the after ECG we evaluated the MRI brain. On MRI brain, it was suggestive of hyperacute non-hemorrhagic infarct in frontotemporal lobes. And we also did the MR angiography of brain and neck vessels, which was suggestive of only atherosclerotic thickening and luminal narrowing in the middle cerebral artery and carotid bulb. No major vessel occlusion was seen. Further, for the evaluation, we looked at the echo. So here is the echo findings of the patient. So on doing echocardiography, we found this is the parasternal long axis view, so which is suggestive of the left ventricular apical clot. We can see that the apex, it seems the dyskinetic, and mild LV dysfunction is there. Inferior wall, lateral wall, they are moving well. Normal movement of the mitral valve leaflet is there. So this is the parasternal long axis view, and we can see well appreciate the LV apical clot. So on further evaluation, we asked the patient, is there any history of chest pain, dyspnea or palpitations? So on detailed history, they told that before 15 to 20 days he had retrosternal discomfort, and for which he consulted some general practitioner and had taken some injectables, but for that they did not do any ECG. So this might be the previous MI, which was 15 to 20 days old, and which was complicated with the LV apical clot, and that clot that dislodged in and caused the stroke, cardioembolic stroke. So on echo, we found out the LV apical clot. Here we can see that the RARV function is normal, RARV size is normal, and mild LV dysfunction, LV apical dyskinesia with LV apical clot. Here we can see the normal RV systolic function. So this was the patient with LV apical clot, the MI which was 15 to 20 days old, which was unrecognized, and now as a complication of that, patient presented to us with the cardioembolic stroke. After this much of the investigations, we did the routine blood investigations in the stroke profile, coagulation analysis, and we explained the relatives regarding the need for the thrombolysis. Now further we consulted the cardiologist, neurophysician. So on cardiologist opinion, they told the risk of dislodgement. There was if we thrombolize the patient, there is a risk of dislodgement of the LV clot, which may further lead to the complication, and there is also a chance of hemorrhagic complications. But because the MI is 15 to 20 days old, and now the major complaint is the aphasia and the facial deviation, we calculate the NIHSS score, which was around 8. So along with the whole team, with explained risk of clot dislodgement, we explained the bleeding risk, and we thrombolized the patient according to the weight with the tenecteplase 0.25 mg per kg single rapid bolus dose, and we did the repeat neuroimaging CT scan immediately after thrombolysis and after thereafter, and there was no any hemorrhagic complications were there, and patient showed the near normal complete improvement in the speech and the facial deviation, around 80 to 90% improvement. And further on discharge, we discharged the patient with the aspirin 75 milligram and anticoagulation dabigatran 150 milligram. We also evaluated the homocysteine level, which were within higher side, so we given the supplements for that also. So patient was discharged with the antiplatelet and anticoagulation, and with almost complete neurological recovery. So here emphasis is on the thrombolysis of the stroke patients, particularly cardioembolic stroke post MI with the LV clot. So according to the guidelines, in the mild form of stroke, say for NIHSS less than 6, the benefit of thrombolysis, it is uncertain. But as we were falling into the moderate category, moderate to severe, and the neurological event was the primary presentation to us, and the MI was 15 to 20 days old, we explained the risk of clot dislodgement, we explained the bleeding risk and thrombolized, then we see the very good clinical recovery of the patient. And for the further any prevention of the embolic events, we prescribe the anticoagulation to the patient. Thank you.